And please.
Okay, I hope you see my slides now.
Yes.
Okay. Okay.
Thank you.
All right. Okay. Thank you for the invitation, and this is my pleasure to be here with you, talking about posterior lateral corner of the knee. And actually, this topic I will highlight the anatomy and MRI appearance of the posterior lateral corner of the knee, and show you when we will call it injured. Actually, this topic is quite difficult to cover within 20 minutes, but because the anatomy is very complex and is inconsistently seen during anatomical dissection. Moreover, sometimes it may not seen on MRI, but it's very important. First of all, it's not that often, but it's usually combined with the injury of ligaments, particularly PCL, the posterior cruciate ligament injury. It helps prevent excessive posterior translation, varus force, and external rotation. And if you left this structure untreated, your cruciate ligament repair will be useless, because finally you will have graft failure and eventually osteoarthritis. So this talk, I want to emphasize that there's a study looking at this particularly structure. By cutting this structure one by one, the major structure was LCL, popliteal fibular ligament, and popliteal tendon. By cutting this, it significantly increased force to ACL and PCL graft. So when you do ACL or PCL reconstruction, you're supposed to look at this structure and make sure that it's still intact. So it may need additional surgical technique to fix these structures. Okay. So MRI, the role of our as a radiologist, we need to confirm the diagnosis. We may need primary repair of this structure if the injury occurs in 3 weeks, and that will be provide favorable outcome, because physical examination during this stage will be overwhelmed by the instability of cruciate ligament injury, and it's very difficult. So our role is to identify these structures. Initially, this structure has been described in very complex way by anatomists. Has been described into 3 layers. For example, the first layer will be more superficial, like bicep femoris tendon. The deeper is the structures like LCL, and the deepest will be capsule structures. This is quite difficult to be understandable, and it may not useful in surgical or it's not very clinical relevant. So I would like to make it simple, and I try to simplify it, and we will focus on the structures we really need to know during the surgery. First of all, lateral collateral ligament. Another group is the group of popliteal fibular myotendinous units, which comprise of popliteal fibular ligament, popliteal tendon, popliteal meniscoclassical. And then the last one will be posterior lateral joint capsule, as well as fibular ligament and axial ligament. So let's look at this structure one by one. Let's start with lateral collateral ligament. It's starting from lateral femoral condyle, go to the fibular head and forming a conjoined tendon with bicep femoris tendon. You will be always be able to identify these structures on anatomy and MRI. And this is how we trace it. Just start from coronal view. You can see bicep femoris tendon. Okay, you can see the lateral collateral ligaments also go to fibular head. Is formed the conjoined tendon with bicep femoris posterior and LCL anterior. Usually, if it's quite difficult to see by coronal or sagittal view, we can use axial view. First of all, start with lateral collateral ligament with its anterior and deep, bicep femoris with its posterior and superficial. Go down with anterior and deep, lateral collateral ligament, bicep femoris posterior and superficial, and finally inserting on the fibular head. Let's move to the anatomical structure with its popliteus myotendinous complex. It's comprised of popliteus muscle, tendon, and popliteal fibular ligament. is because it has muscles, so it helps in dynamic and static resistance. It's not only prevent varus force, but it also prevent external rotation and posterior translation. Proprietary tendon starting from tibia and go to interior aspect of proprietary sulcus always be able to identify on anatomical and MRI. Popliteal fibular ligament starting from myotendinous junction of fibula. Myotendinous junction of popliteal fibula of the proprietary muscle and go to fibula is always identified on anatomical dissection, but unfortunately for MRI, you may be able to see it's about half of them. So let's look at this structure. How to trace this is from anterior sulcus of infemoral condyle and go down. You can see it at the posterior aspect of here. Why you can trace popliteal fibular ligament from myotendinous junction and then go to fibula. And this is how we trace it. First of all, look at coronal view. You can see proprietary tendon inserting at lateral aspect of the femoral condyle, where you can find the bone that curve and deep down at the proprietary sulcus. Then look at sagittal view. You can see tendon, myotendinous junction, and finally the muscle, which we can look on MRI by looking at tendon, myotendinous junction, and finally the muscle. And on axial view, you can look at posterior tibia, go up, and up, and it will insert to femur under LCL. And this is how we can identify this complex structure. Let's move forward to popliteal meniscal fascicle. It's running from posterior horn of lateral meniscus to popliteal tendon sheath. You will usually be able to identify posterol superior and antero inferior band, and sometimes you can be able to identify posterol inferior band. It will be found on anatomical dissection, but on MRI, roughly about 60 to 90% will be identified. A rupture of posterol superior band, usually associated with posterior horn of lateral meniscal tear. So whenever you find tear of the meniscus, carefully look at this structure. So the next one will be quite fine and may be quite difficult to be identified on MRI. Actually, is the cruciate ligament and fibular ligament. Cruciate ligament has two limbs, has medial limb that attach to the joint that you can be able to stay traced from the ligament to posterior joint capsule, and that area of joint capsule will thicken a little bit, will be called its proprietal oblique ligament. The lateral limb attached to fibula. Usually we can be able to identify this limb, but it's quite difficult actually. Anatomical visualization may be about 80%, but MRI may be only half of it. And to look at this arcuate ligament, I usually look at the axial view, look at the area superficial to proprietary tendon. First of all, identify proprietary tendon, and then look at the ligament, which is superficial to the tendon. Let's move forward to fibular ligament. It runs from fibula to fibula if you have fibula. If not, you will have the ligament running from lateral femoral condyle to fibula. Anatomical visualization mostly about 80%, and MRI visualization for half of them. It helps retain all together with joint capsule to retain external rotation and varus angulation. And this is how to identify it. If you're lucky enough to see this structure, first of all, try to look at fibula, and this will go down to the tip of fibular stenoid. And this is how to identify it on coronal view, the big fibula bone, and then the ligament is here, and it will go lateral to popliteal fibular ligament. When we have injury of this structure, we may look at directly disruption of this structure, or look at some type of fracture that suggests that is the insertion site of these structures. Also, try to identify bone contusion, which is the hallmark of injury that lead to the injury of these structures, and also soft tissue edema around posterior lateral corner structure. First of all, look at fracture. Acute fracture is the avulsion fracture of fibula at the site of the attachment. It can occur as fibular styloid process, where the insertion of proximal fibula arcuate and fibular ligament insertion. On the lateral margin, which is weaker structure, is LCL or biceps femoris. Here the example of fibular styloid process, where the proximal fibular ligament inserted. There's a small fragment of bone pulling from fibular styloid. Sometimes it may be difficult to identify this small fracture on AP view. You may use oblique view to identify this fracture. And this is the MRI of the case that has small fragment pulling by avulsion of proximal fibular ligament. And this is proximal fibular ligament with avulsion fracture. The lateral margin, because conjoint tendon biceps femoris and LCL is big, so usually the fracture is bigger and collateral. So look at this one. This is the attachment side of biceps femoris, and the structures pull the fractures upward away from the fracture site. When you try to identify the structure, remember tendon and muscle can be contracted. So you can see biceps femoris, but the avulsed ligament, the ligament cannot change the length. So the ligament will fold up and may look wavy. So this is a ligament that attached to the avulsed bone fragment. So this is the way to identify the structures when it has injury and everything is quite difficult to be identified. Rupture can occur at the fibular insertion site or can occur at the femoral insertion site. When you find disruption at the distal insertion, carefully look at bicep tendon injury because it can be associated about 90%, so quite a lot. And when you have rupture at the proximal insertion, carefully look at proximal tendon avulsion. And it's about 70 or 75% will be co-associated that you have wavy tendon and avulsion tendon from the femoral insertion site. Proximal tendon injury is quite easier to identify as the proximal sulcus insertion, while you can see normal tendon at the sulcus. This patient, you cannot see anything at the sulcus, so this indicates injury. As Dr. Jung has told you, myotendinous units is the where you can get injury. Try to identify the muscles and look at the abnormal signal intensity in the muscle. This indicates partial tear, does increase signal intensity in muscle belly, while you have some disruption of fiber. And in chronic injury, it's made quite difficult, but you may see fatty atrophy within the muscle, and you try to trace from the tendon that's gone, and there's a chronic rupture that you cannot see anything here, and finally fatty atrophy of the muscle. Proximal fibular ligaments, if it's ruptured, the way to identify it is this is a comparison of normal anatomy. This is, you can see the curve, nice proximal fibular ligament running from myotendinous junction. This is the wavy of ligament that has avulsion from fibular insertion. Another one, when you can find proximal tendon and proximal fibular ligament injury, normally the curved normal tendon, and this is the wavy proximal tendon. When you also have the stump of proximal fibular ligament here. And don't forget to look at the fascicle, where you can have a clue with lateral meniscus injury. Whenever you find lateral meniscus injury, look at this fascicle. And posterior joint capsule and cruciate ligament is quite difficult. Arcuate ligament is quite difficult to be identified during acute injury. So look at the joint capsule, where you can see wavy joint capsule and disruption of joint capsule, the leaking of fluid. That will be the clue of posterior lateral corner joint capsular injury. Or finally, you may cannot see anything that's indicated chronic injury with scar, everything scarred. And look at indirect sign, which is bone contusion. Anteromedial tibial plateau or femoral condyle. That indicates that the right direct bone occurs when the knee has hyperextension, varus force angulation, either in external or internal rotation. That indicates that when you have direct growth from the medial side, anteromedial side, this posterolateral corner is the concave lesion that's prone to injury. And finally, try to look at complication. This is common peroneal nerve injury. Denervation of muscle may have hyperintense on T2 with that images, but it's not edema because you have atrophy of muscle on T1 with that images, and that indicates common peroneal nerve injury. And finally, you can help the patients by looking at the case in acute phase. This gentleman has multiple fractures and also have knee dislocation and posterolateral corner disruption. And this is how we identify its rupture of popliteus tendon, popliteus tendon, popliteus tendon, and nothing there at the sulcus. We can identify lateral collateral ligament, lateral collateral ligament, and lateral collateral ligament, but nothing in femoral insertion. And finally, this is what we found on during surgical findings, when you can see the lateral collateral ligament, lateral collateral ligament, lateral collateral, this is disrupt, and finally popliteal fibular ligament stump, and this is the tendon that is disrupted. So I want to wrap up everything that this is important, that helps stabilize the knee, and it needs to be identified when you gonna treat the patients with ACL or PCL grafting. And it's easier to identify it in three groups: LCL, popliteus, myotendinous unit, and posterolateral joint capsule. Finally, look at disruption of this structure, look at arcuate fracture, soft tissue edema, and bone contusion. And don't forget to look at complication of peroneal nerve denervation. Thank you for your attention, and I'm happy to take questions after this session.
Thank you so much, Professor Nuttaya. And please stay with us at the end of the session for the